Next, we have Dr. Stephen Ye from Atlanta, Georgia, talking about fluorescein angiography.
Yeah, thanks, Bob. Thanks, Russ. Thanks again to the AUS Executive Committee for the opportunity to present to you on fluorescein angiography in the white dot syndromes. I'll be going over and reviewing some of the concepts that we haven't yet covered with respect to the clinical management of these conditions in the context of fluorescein angiography. These are my financial disclosures. First, I'm going to discuss some of the distinct fluorescein angiography patterns in select white dot syndromes. I'll be providing some clinical examples in FA for the diagnosis and some of these secondary complications that we see in the white dot syndromes. And also, this isn't done in a vacuum. We use multimodality imaging for the recognition of white dot syndromes and how the fluorescein angiogram still fits into our evaluation. So I'll start with this case. This is a 40-year-old male patient who had complaints of floaters and debris for 2 years and was status post-laser retinopexy for some suspicious appearing lesions. His slit lamp examination showed 1+ anterior vitreous cell in both eyes. You can see that there's some trace vitreous haze and some mild optic disc edema. And what you can see when you look at the optic disc is that there is some optic disc hyperfluorescence with leakage, and when you look at the vessels, you can see there's this characteristic segmental periphlebitis. You really don't see the birdshot type lesions. In the left eye, the segmental periphlebitis is perhaps even more prominent, again, with this optic disc leakage. In the late frames of the angiogram, you can see this RPE blush. And so you look a little bit more closely at the ICG, you can see multiple hypocyanescent lesions that really define this disease phenotype. This patient did not have the sequelae of cystoid macular edema, but again, he did have these lesions and symptoms for 2 years. You can see this is even more prominent again in his left eye. So you see sort of a paucity of lesions within the fluorescein angiogram, but you see more of these lesions with the ICG. So it really is important to use this paired with ICG when you suspect this disease condition. Now, what we know from our individuals from Hopkins and our colleagues is that birdshot can lead to severe cystoid macular edema as one of the changes that leads to visual acuity. You can see that there is chronicity, and this gentleman, he was a CIA agent who developed birdshot. He also had this diffuse RPE blush from disease chronicity. When you look at his OCT, a number of different findings, including intraretinal and subretinal fluid, as well as an overlying epiretinal membrane, which in some cases may actually reduce the likelihood of improved visual acuity. He fortunately did improve with local and systemic therapy. His left eye, similar findings. You can see this petaloid appearance of a cystoid macular edema in the late frames. And again, he had disease chronicity, so you can see this diffuse RPE blush on fluorescein angiography, indicating that he needed an anti-inflammatory and systemic therapy. Another complication that we do see in birdshot as well, this is a lady who actually had bilateral disease. She was 53 years old, HLA-A29 positive, and actually had bilateral distortion. Visual acuity was 20/40 in the right eye, which I'm showing. On her OCT, you see this subretinal hyperreflective material overlying this area of this pigment epithelial detachment. And again, fluorescein angiography, I think, still has a role. You see this hyperfluorescence early in the angiogram with this leakage, both within the area of the choroidal neovascular membrane, as well as optic disc leakage, suggesting that she had both an inflammatory component as well as a neovascular component to her disease from this macula-involved birdshot. She was treated with adalimumab and serial anti-VEGF injections with good effect by angiography and OCT. CNV in birdshot is thought to occur in about 5 to 10% of patients with birdshot. The risk of choroidal neovascularization, we think, is not surprisingly increased in risk with the macula-involved cases, and it's important to think about combination therapy in this context. Now, moving on to AMPI, acute posterior multifocal placoid pigment epitheliopathy. This was a young lady who was about to go to medical school who presented with visual acuity loss at the 2100 level. You can see these placoid appearing lesions on her fundus photograph. And the fluorescein angiogram shows this characteristic early hypofluorescence with late hyperfluorescence signal throughout the posterior pole, and she had some distortion symptoms and was initially started with oral prednisone by an outside provider, but she discontinued it, unfortunately, for unknown reasons, and it turns out she presented with this dramatic decrease in her visual acuity. In her left eye, she had these lesions overlying her fovea. You can actually see this small lesion just superior to the fovea. She was 20/20, but has these lesions encroaching on her fovea. So we were certainly concerned about this disease process. She had hypofluorescence early with late hyperfluorescence, which was diffuse and subtle over these lesions in the superior temporal quadrant. She had a laboratory workup, was unrevealing for any other infectious disease conditions. As Dr. Jampol mentioned, that it's important to rule these out. And because of the fovea-threatening lesions and the bilaterality, she was treated with IV solumetrol for 3 days, oral prednisone taper, and again, she had these vision-threatening lesions. You can see this disease improvement at the 1-month time point, improving to the 20/40. She eventually improved to the 20/25 level in this right eye. Left eye, similarly, these lesions that were encroaching on the fovea that had all of us pretty anxious about her potential disease outcome. She recovered to, and she maintained her 20/20 vision. Now moving on to serpiginous, which when you look at the textbooks talk about early hypofluorescence with late hyperfluorescence, but I really think that the fluorescein angiography pattern is quite different. This patient actually was seen at the National Eye Institute. He had a visual acuity of 20/30. His early phase angiogram does show hyperfluorescence, and there's just some staining during this period of disease inactivity. He was 40 years old, again on several immunosuppressive medications. Again, when you look at the fundus autofluorescence, which is one of the key imaging modalities for serpiginous, you can see that you can see this area of large hypoautofluorescence that corresponds very tightly to the fundus photograph. So he actually came in with a complaint of a new scotoma in the right eye. In the course of a busy retina or uveitis practice, I think you would be hard-pressed to really drill down to this little area where perhaps he was developing these symptoms. And there was, again, still hypofluorescence early with perhaps some late hyperfluorescence at the border of this lesion. The question is whether there's disease activity that warrants additional treatment. And in this situation, while fluorescein angiogram is consistent with active inflammation, the fundus autofluorescence is really much easier to interpret in the context of a busy clinic, and we found to be a marker of disease activity. And really, so fluorescein angiogram in this context should be used with the fundus autofluorescence. Now, punctate choroidopathy, which Arthur nicely summarized as well. This is a 27-year-old myopic female. She had a history of punctate choroidopathy with some scotoma previously documented in the left eye, who came in with some new distortion symptoms in her right eye. And the question was whether this subtle yellow blush represented choroidal neovascularization versus inflammation. This is where I think the fluorescein angiogram really comes in handy. Obviously, there's a role for OCTA as well. But early in the angiogram, the venous phase angiogram, this is quite unremarkable. But as you look at the later frames of the angiogram, this is actually quite far out. You can see there's this diffuse hyperfluorescence with leakage. We interpreted this as an active inflammatory lesion, and she was treated with a tapering course of prednisone, which was initiated at a 1 mg per kilogram dose. And you can see that post-corticosteroid, we followed her with serial fundus photography and OCT. She deferred further fluorescein angiography at that point, and you can see her lesion has nicely resolved with treatment. This is another complication, as we know has been well described, choroidal neovascularization in the context of punctate retinochoroidopathy. It occurs, we think, in 70 to 80% of PIC patients. And this is, there's this high risk of these findings. And so what you see here is that fluorescein angiogram, you can show that there's this early hyperfluorescence with this area of subretinal blood and late leakage indicative of choroidal neovascularization that really should be treated with anti-VEGF therapy. And in some cases, if there is ongoing inflammation, then sometimes combination therapy is indicated. This is another case of PIC. Again, fluorescein angiography highlights really this choroidal neovascular lesion in terms of the extent. You can see this well-demarcated area of hyperfluorescence. I don't know that we use the term classic lesion as much as we used to, but again, well-demarcated hyperfluorescence early with late hyperfluorescence and leakage that documents the area of the PED and the extent in association with punctate choroidopathy. And lastly, referring to multiple evanescent white dot syndrome, again, female preponderance, unilateral in 80% of cases. We've mentioned this earlier as well, but about 1/3 of patients report a viral prodrome. And really, we feel that this falls in the acute idiopathic big blind spot spectrum of disorders. This is courtesy of Dr. Tom Albini. These are so evanescent that we actually don't see this very often in our practice. But what we saw is that in this case that Tom showed, you can see there's this hyperfluorescence with these areas of foveal granularity. There's also sometimes you'll see these areas of hypocyanescence on ICG as well. So in summary, fluorescein angiography really remains a key imaging modality with very subtle patterns that we can see and very characteristic patterns with birdshot, AMPI, serpiginous, and PIC that can help distinguish these disease diagnoses. We use this on initial evaluation. We think it's extremely valuable for not only the diagnosis, but also recognizing structural complications. But in many cases, monitoring may be performed by other imaging modalities depending on the diagnosis and their secondary manifestations. And again, these disease recurrences and complications can be highlighted by FA findings. And so it still remains a valuable tool for the white dot syndromes. Thank you.